So welcome everybody to our third AHP Workforce webinar that Health Education England are putting on. My name's Paula Breeze. I'm an AHP Clinical Fellow with the National Health Education England team for the next few months, and my role has been largely supporting the implementation of AHP faculties across the country, but I'm also organising a series of 5 webinars around AHP workforce. So very warm welcome to you all, and thank you for joining us this morning. And this morning we're going to be talking about dietetics, drama therapy and paramedics. So the purpose of the webinar is as a follow-up to our AHP faculty showcase that we had recently to celebrate the development of AHP faculties and the evaluation findings. And one of the main findings of the evaluation was that our AHP leads and chief AHPs need to be equipped with data. They need to be equipped with data and information so that they are able to have really informed conversations with their HRDs and their system leaders, and so that they really are optimally equipped to advocate on behalf of the 14 professions. And what we want these webinars to do is to provide you with that information so that you've got a really good understanding and feel that you've got a handle on all the challenges and opportunities that face each of our 14 professions and your workforce, so that you are in a good position to provide advice and guidance. So that's the purpose of the webinars and the background. Next slide please, Sharon. So in terms of housekeeping, so if you can all put yourselves on mute and turn your cameras off unless you're speaking. The webinars are being recorded and they will be put on the HE AHP faculty page following the webinar once we've got them uploaded. I'd like to welcome Lucy Locks, who is going to be monitoring the chat box. So rather than keep putting your hand up, if you could put your questions and comments as we go through the webinar in the chat box, then some of our colleagues, I think we've got Naomi McVeigh here also, who will be able to help to answer some of those questions. So welcome, Naomi, and we'll answer them as we go along. And then towards the end of the session, we will have time for discussion. We've got Beverly Harden joining us later on. I think she's joining us about 12, which is when the discussion is starting. So Lucy will be keeping an eye on the chat box, and we've still got quite a few people joining us, so welcome to those that have just joined us. If you're a Twitter fan, please, we've got the hashtag AHP faculty, please tweet, that would be fantastic. And can we move on to the next slide please, Sharon? So today's plan, so we're going to start off with dietetics and we're going to have a presentation. Sorry, please can you put yourselves on mute if you're not speaking. Thank you.
Yeah. A rig.
Oh dear.
Right.
Hello, whoever that is, please could you put yourselves on mute? So we'll start off looking at some workforce data around dietetics, and then we're going to hear from, we're delighted to have the professional body representation for each of the professions today. So they'll be able to give us a perspective from their, a view from their perspective on what the workforce challenges are for their profession. So we will talk about dietetics, then we'll move on to drama therapy, and then we'll finish off talking about paramedics. And as you can see, it follows a similar format. Okay, so next slide, please. So to kick us off, I'm going to introduce you to Shagufta, and she's going to talk you through some workforce data. Thank you, Shagufta.
Thank you, Paula. My name is Shagufta Khan. I'm a National Workforce Planner from Health Education England, and today I would like to share dietetics workforce data with you. Next slide, please. Starting with registration data. Dietitians are regulated by Health and Care Professions Council. HCPC regulate 13 of the 14 AHPs within the UK, with osteopaths being regulated by the General Osteopathics Council. The highlighted column in this table shows you how the number of dietitians registered with the HCPC have changed over the years. The data in the table shows that the number of dietitians increased from 6,663 in 2008 to 9,722 by the financial year end 2018-19. And the latest HCPC figures show there to be 9,693 dietitians on the register as at August 2020. Next slide, please. This graph shows the number of dietitians registered with the HCPC compared to the number of registrants employed within the NHS, and we've used the NHS digital data here for part of the graph. I would like to point out that the HCPC numbers are UK-wide, and the NHS digital data used here is for NHS in England only. Between 2014 and 2020, the number of dietetics registrants increased by 19%. What is also evident by this graph is that the NHS is not the only employer of dietitians. Many work in other organisations and sectors such as private practice, education, government, sports, just to name a few. Next slide, please. For historical supply trends and information, we use both NHS digital data and data from ESR Data Warehouse. As can be seen here, there are some differences in the number of dietetics reported by the two data sets. Our ESR numbers are slightly higher as we count all staff, such as those on maternity leave, and the NHS digital numbers only include frontline staff. However, please note the trends are largely the same, with both data sources showing a 3% growth for this profession. Next slide, please. Flow analysis on the supply information for dietetics shows us that dietitian numbers in the NHS grew by 2.7% per year between 2015 and 20. UK joiners have remained stable at 350 per year, and international recruits have remained around 100 per year, with the exception of 2019-20, where the numbers went up to 127. Finally, retention efforts seem to show success, with leaver rates falling from 7.1% in 2015-16 to 6% as seen in 2019-20. Next slide, please. This table shows us the regional data for dietetics. The size of dietitians employed by regions is reflective of services provided and demographics of that region. And so it can be seen that the largest employers of dietitians in 2020 include London, North Eastern Yorkshire and North West, which is in line with where the main course providers are located. Next slide, please. Demographic data for dietitians show us that 93% of the workforce is female. The age profile data for dietetics shows us that 45% of the workforce are age 35 or under, and only 17% are age 50 or over. Due to the good distribution of dietitians in the different age bands, there is no immediate risk of workforce supply due to an aging workforce. Next slide, please. The ethnicity data shows us that 72% of the NHS dietetics workforce are white British, and 10% of the dietetic workforce are from a BAME background such as Asian, Black, Chinese or other ethnic background. The nationality data shows us that the percentage of staff with a non-UK nationality is stable around the 11 to 14%, which in 2020 figures is around 645 out of the 4,700 workforce. Regional data on nationalities shows us that 24% of London's dietetic workforce is of a non-UK nationality background. Next slide, please. HEE tools have been used to understand the supply and demand requirements of dietetics workforce. The analysis shows us that the supply is expected to grow by 3% per year based on historical trends. Demand is harder for us to determine, but we would expect it to grow by the same amount given the requirements within the long-term plan and due to the demand required within primary care as part of the 26K expansion. Further interventions may be required in order to keep up with the demand requirements. Next slide, please. In summary, it can be seen that the NHS is not the only employer of dietitians. Many are employed outside of the NHS in England and in other sectors. Workforce data shows us that both dietetics registration and workforce numbers have increased over recent years. Higher international recruitment numbers are seen around London and east of England, which may suggest some capacity issues within these regions. Overall, the prognosis for dietetics is reasonably optimistic due to solid growth in profession and the young age profile of the workforce, but further interventions may be needed to address the demands from the long-term plan, namely just a few of them, such as reducing number of adults living with obesity, halving childhood obesity by 2030, and the expansion of the NHS diabetes prevention programme. Thank you very much. And now I will hand you back to Paula.
Thank you, Shagufta. That's great. I'm now delighted to hand you over to Mena Winwright from the British Dietetic Association.
Thank you very much for the invitation to present to you today. This presentation will provide you with an overview of the profession and describe the opportunities and challenges ahead to deliver high-quality dietetic services across a variety of settings. Next slide, please. To build on the information you have just heard, some additional statistics around the dietetic profession. 79% of the 10,000 HCP registered members are BDA members, and we currently have 18 HEIs delivering dietetic courses both at undergraduate and postgraduate level, with many new courses coming on board imminently. And the map shows the current distribution of these courses. In addition, we have around 200 BDA dietetic support workers. Next slide, please. To provide some context, dietitians are the only qualified health professionals helping people make informed and practical choices about food based on the science of nutrition. The importance of food and nutrition in influencing the health and well-being of individuals and populations is gaining greater focus and priority. The dietetic workforce is changing at great pace, with the profession in demand to work across a plethora of areas, including health and social care, public health, and to remain better. This breadth in workplace setting is reflected in the diagram on the slide. Next slide, please. National directives, for example, the long-term plan and people plan, are transforming the way in which care is being delivered, focusing on transferring care out of the acute sector and implementing an integrated care agenda delivered by multidisciplinary teams in both community and primary care settings. Advanced level care is prioritised as a way of addressing the needs of an ageing population and patients with complex long-term conditions. And additionally, there is a push for individuals to engage in self-care activities, taking responsibility for their personal health and well-being. Dietitians are well placed to respond positively to this agenda, as the profession can work flexibly across boundaries and manage change. The current level of demand is outpacing the growth in the profession, and we need to meet this challenge. There has been a significant increase in the number of dietetic training providers and students over the past few years, and is continuing to grow. And whilst this is very positive, if we are to meet demand, we will need to attract more potential students to apply, increase clinical practice-based learning opportunities, diversify in terms of settings, and secure appropriate placement funding. Furthermore, there are still dietetic departments which currently do not accept dietetic students for clinical training, and this must be addressed. Innovation is taking place, including the promotion of new models of supervision and developing options such as clinical simulation. Whilst these initiatives will certainly improve capacity, to develop and enact them requires time, investment and support from senior levels. There has been a huge amount of interest in the development of the pre-registration apprenticeship as another route into the profession. Many of our invaluable dietetic support workers are keen to upskill and become qualified practitioners. The standard has been developed and a training provider is currently going through the process of being registered. But in preparation for this, it is important that we see the development of Band 5 roles and reskill mixing of teams needed to support apprenticeships. It is also important that dietitians are supported to return to practice and have the flexibility to work in a way that supports them but still makes use of their skills to support good quality care. Otherwise, we risk losing experienced and valuable members of the profession for longer. Individuals can access return to practice schemes. However, the limiting factor is again the same as pre-registration students in the availability of clinical placements and clinician time for supervision. BDA offers a range of resources that can help an individual's period of updating, including CPD tools and resources, expert advice and access to policies. Dietitians are embracing change and looking at all the ways that they can utilise their clinical and non-clinical skills to adapt to roles to suit their service users. They are embracing advanced practice as a way of ensuring that services users see the right healthcare professional first time in the right place with the right skills. Investing in master's level education and training and building a common understanding of advanced practice offers exciting and career changing opportunities for dietitians. And these have direct implications for roles in leadership often filled by doctors, nurses and other AHPs. The GP contract has committed to broadening the workforce in order to reduce demand for GP time and connect the service user directly with the most appropriate professional. This has led to a demand for dietetic services, particularly in gastroenterology conditions, to be provided as that first contact practitioner. These roles aim to bypass the GP and leave the dietitian to lead the patient pathway, make the assessment, diagnosis, order the relevant tests, and plan care and review, referring on to other services as necessary. However, there is a gap in the relevant resources required to develop and quality assure these new roles for dietitians, including governance, training, and competency. Next slide, please. To summarise, what do we need going forward? A key action is to prioritise practice-based learning across all specialities. Without significant investment in placement provision, growth and opportunity is under threat. COVID-19 has exacerbated the challenges in finding sufficient placement capacity that has already existed, with hard-working dietetic teams struggling to offer the quantity and quality of placements needed. There is a need to support new providers, both clinical and non-clinical, to participate in student training. A second action is to prioritise graduate jobs. We need to ensure that once dietitians qualify, Band 5 jobs are available across all regions of the UK. This will enable dietitians to gain the experience needed to develop their career and progress into the kinds of roles that are demanded by the system going forward, for example, ACP. Preceptorship programmes play a vital role in this also, and we need all service teams to engage with preceptorship programmes, helping to build confidence and expertise in the first years of practice from novice to specialist. This reduces attrition from the NHS and lays strong foundations for more specialist and advanced practice. It is vital that we harness the interest in food and nutrition and channel it into considering a professional career in dietetics. We need schemes and campaigns within schools which must focus particularly on the promotion of smaller professions in order to ensure they remain attractive as a career path. As indicated, the dietetic workforce remains overwhelmingly female. In line with the equality, diversity and inclusion agenda, more needs to be done to make the profession appealing to men and to ensure that anyone, regardless of race, socioeconomic background, etc., can become a dietitian if they have the skills and desire. And finally, we ask that we all look ahead and fully understand the strength of the impact that dietetic services can make in the delivery of care, particularly through initiatives working in primary care, which can reduce demand on acute gastro outpatients. We must not also underestimate the increasing demand for services such as obesity and mental health eating disorders and the lead role dietitians play in delivering these services. Next slide, please. And finally, I would like to leave you with a message that dietitians work closely with all other health professionals and can teach them how to optimise dietetic aspects for their care across all specialties. Thank you for your time.
Thank you, Menna. I think you'll agree that was really interesting, and I hope that you're going to find the combination of the data with the views from the professional bodies about the challenges and opportunities a really useful package that you can then take away with you back into your organisations to have those conversations. And the slides and the recording will be made available so you can use this information going forwards. Okay, so now it's time for us to move on to drama therapy. And I'd like to hand you over now to Thomas Speller, who's going to provide you with some workforce data.
Thank you very much, Paula, and good morning, everyone. My name's Tom Speller, and I'm Deputy Head of Workforce Planning within the Modelling Medical and Dental team in HE, and I've worked quite closely with Shagufta on HPs. I learned this week that drama therapist is all one word, so I think proving the point that certainly in me and Shagufta's line of work, you learn something new every day, and the format will be quite similar to what Shagufta presented. So if you go to the next slide, please. Yep, so we can see registration data, and I think the main thing to say about it is that with AHPs generally, there's 3 broad groups. So podiatry, you see not very much growth over the last 10 to 15 years. Most professions you see about 2-3% growth a year, and then there's a third group where you get much faster growth, and art, music and drama therapists, which are grouped together, are in that third category. So you can see that in 2008, about 2,500 registrants, goes up to 4,400 by 2018-19, quite rapid growth. thing to make clear from the outset here actually is that art, music and drama therapists, both in terms of registration data and ESR data, tend to be grouped together. So what I'll do is I'll kind of, where appropriate, I'll talk about arts therapists, but where appropriate to make specific references to drama therapists. And that'd be quite key later on, because as you'll see, there's not very many in the NHS who are specifically drama therapists. Next slide, please. So you can see the blue line shows the growth of UK registrants over the last 6 years, from 2014 to 2020, and you can see that there was a growth of about 1160 in 6 years, or 32%. So that's really quite strong growth. You're looking at 5% a year, and in recent times it's slowed down a little bit. So we can see that in August 2020 there were 4,461 registrants, so it's quite a small increase on the end of 2018-19, about 0.6%. So that might suggest there's some slowing down. The really interesting thing is the green line at the bottom though, which shows data on NHS Digital, which is staff that are recorded in the NHS. And what's very, very clear is that the majority of registrants in the UK don't work in the NHS in England. Now, some of it will be because simply you'll have people who work in the rest of the UK. What the main reason is that a lot of arts therapists work in other sectors, specifically education, the third sector, charity and private practice. So you can see it's arts therapist is a very small profession in the NHS. You're looking at really less than 500 FTE or fewer than 500 FTE. Next slide, please. As Shagufta said, we do a bit of a contrast between NHS Digital and ESR Data Warehouse, so there are some differences. We tend to go with ESR Data Warehouse because we count all employed staff, whereas Digital counts frontline staff. The thing here is that the trends basically give you the same thing. So within the NHS, you're looking at 3-4% a year for arts therapists. When turning to a drama therapist specifically, and there's a definition on the bottom because the only way you can identify them is looking at job role, you can see that the numbers are really, really very small. You're looking under 30 FTE. It's remained stable about 25 FTE per year, and that's about 5-6% of the arts therapist workforce. So given these small numbers, which does limit on what we can sensibly report on, I will focus most of the remaining analysis on arts therapists as a whole, but I will give additional insights to drama therapists as appropriate. Next slide, please. So we can see that generally for arts therapists, your growth's typically about 3-4% a year. Your growth in UK joiners has gone up from 15 to 35. So in theory, it's a growing profession generally. International supply is quite small. So you're looking at about 5 to 10 FTE a year, peaking at 10 actually this year. And your leaver rates are now quite low, so about 5.5% in 2019-20. Just need to be aware that because it's small numbers, you do get big fluctuations. For drama therapists as a whole, really it's very small trends, so you get very small numbers leaving and joining each year, i.e. less than 5 FTE. Really not an awful lot of international recruitment, if at all. Next slide, please. You can see the variation in arts therapists by region, and you can see that there's quite a lot around London and the commuter belt, so that's quite apparent from the data. For drama therapists as a whole, about 3/4 are in London, East of England and South East, so a definite regional bias there. Next slide, please. Bit of demographic information here, so we can see that the majority of arts therapists as a whole are predominantly female, about 93%. Drama therapists, very similar trend, it's 87%, so not really much difference between the two. In terms of age profile, it's art, music, drama, arts therapists as a whole tends to be a much older profession because people tend to start in their 30s as it's a postgraduate qualification. Similarly, same thing for drama therapists, over half are aged over 50. Next slide, please. Bit of ethnicity and nationality background as well. So vast majority are from a white British background. For only 4% of arts therapists as a whole come from BAME backgrounds, so really quite low. For drama therapists, fewer than 5 FTE are from BAME backgrounds, so really, really tiny numbers. In terms of nationality, it's numbers of it's actually not 7 to 12% as there, it's actually 6 to 10%. So that's about 50 out of 440 arts therapists, and you tend to get more in London. Compared to the rest of the country, although you get a few in East of England as well. And for drama therapists as a whole, again, not very many people, fewer than 5, and they tend to be in London. So next slide, please. Yeah, so looking further ahead then, I mean, all else equal, we would expect pretty solid supply growth, both on the register and within ESR, although for NHS you have to be aware that numbers are quite small and therefore more subject to sudden fluctuations. Whilst we might have expected similar levels of demand growth pre-COVID, it's likely that actually demand for these professions will increase quite considerably, not least because there's increased focus on mental health and psychological therapies, of which arts therapists and drama therapists will actually need to be part of. So this in a way is a challenge and an opportunity for the profession, and further investment in both arts therapists as a whole and drama therapists will continue to be necessary. The additional point I would make for drama therapists is it's small numbers, not very much change year on year, and because your numbers are so small, actually what you need to look at is more succession planning rather than workforce planning. So because often you'll get one or two people leave and then one or two will need to come in, and again this may change if there's an increase in demand post-COVID potentially. So final slide. Yeah, so in summary then, significant proportions employed outside the NHS in England, really quite obvious from the numbers. There's been quite an increase in recent years in terms of numbers, and so on the surface it looks reasonably positive, but the big unknown really is how much demand will change due to growth in demand for mental health and psychological therapies, and that's the thing we'll need to be aware of, particularly for drama therapy, where really your numbers are quite small, and if demand goes up considerably, what we may be facing is actually a possible shift in thinking actually in terms of how you plan for this profession. So that's a summary. Thank you very much.
Thanks, Thomas. Hi, good morning, everybody. My name is Lucy Locks, and I'm an allied health professional leadership fellow working for Health Education England across the South East region. It's lovely to see so many colleagues from the region on our webinar today. So I started my career, and it was a very long time ago, as a drama therapist, working across learning disability and mental health services. It's a fantastic career, and so I'm absolutely delighted to welcome Claire Hubbard to the session to give a view from the professional body today, and she's from the British Association of Drama Therapists. So I'd like to hand over to Claire.
Okay, thank you, Lucy. Hi, I'm Claire Hubbard. I'm convener of the NHS subcommittee in the British Association of Drama Therapists. I'm also Arts Therapies Lead in Adult Mental Health Services in Hertfordshire Partnership University NHS Foundation Trust, and have been working in that trust for about 20 years. Next slide, please. So drama therapy, as has been said, is a small profession. It's often under the radar in health and social care. Like other arts therapies, it is a regulated profession, and it's recognised as a psychological therapy both by NHS England and by the HCPC. Drama therapists use an extensive repertoire of drama tools to meet the needs of the individual or group through dramatic distance, utilising the healing capacity of the imagination. This might be stories that resonate with the individual's own story, where themes, experiences, the characters' motivations and feelings perhaps can be explored. It might be choosing images, such as postcards, to get in touch with and express feelings and memories. Or it might be small objects or buttons or puppets to explore aspects of self or relationships, or it might be physicalizing through movements and enactments. The arts therapies are recommended in the NICE guidelines for psychosis. The links on this slide will take you to 2 drama therapy examples on the NICE shared learning pages that demonstrate how the guidelines have been applied. Next slide, please. So these pie charts were taken from a BADSA workforce survey in 2017 with the results of 266 full members' responses. So as Thomas said, they show that 43% of drama therapists work in the public sector, 34% in the private sector, and less than 20% in the voluntary sector. But it also shows that 22% work in the NHS, in comparison to 58% that work in education. So as you can see, the majority of drama therapists do not work in the NHS, but they may work in sectors that prevent people needing to access NHS services, such as schools and charities. Unlike other healthcare professions, demand does not outweigh capacity if we were to look only at current drama therapy specific posts. Many of those are part-time and are not difficult to recruit to. Many drama therapists, however, work under generic titles such as mental health practitioner or under psychological therapies roles, and they may not show up on the data. Drama therapists often work with those who have struggled to engage with other interventions, who find verbalising their experiences difficult for many different reasons. For example, through trauma, dissociation, difficulties with cognition or with language. When the NHS struggles to appoint to psychological therapy posts, they could look to drama therapists, specialists in group work and versatile in their approach. This has been evidenced this year by how well we have been able to move drama therapy online. But although highly valued on the ground, we are often overlooked for new commissioning and we struggle to have a voice. In reality, there are very few lead or head posts and most of those are in the South East. There is limited capacity for career development. Experienced drama therapists become stuck in Band 6 posts because there is little movement in Band 7s. With training now centred in the Midlands and South East, it has proven difficult, however, to recruit drama therapists in the North, who cannot afford to move for part-time positions that may also be temporary. As a master's level postgraduate training, drama therapy is often self-funded. It's always self-funded. There are currently 4 courses in the UK, Derby being the furthest north. All are now full-time courses. Those that train are therefore truly committed. But having no assistance with fees makes the course inaccessible to those without the financial resources. We now have the Arts Therapies Apprenticeship Standard published, which is brilliant. But now we need to implement it with employers and with HEIs to help our case around inclusion and diversity for our profession. There does need, however, to be job opportunities on graduating from the apprenticeship. Limited posts create a challenge for student placement capacity in the NHS, where it's obviously preferable to have a drama therapist providing the patient placement supervision. Next slide, please. Okay, so looking forward, what do we need and what do we want to do? In looking to the future, we need support to get the apprenticeship off the ground, or funding of training places to enable access to all and to increase the diversity of the profession. We would like to see an HEI in the North set up a drama therapy training. We invite commissioners, senior managers. Someone's got a dog barking, I think. I don't know if they can mute. We invite commissioners, senior managers and chief AHPs to consider drama therapists in the mix for new commissioning of psychological therapies. We would like to see equal opportunities for career development as we see for other NHS professions, recognising the leadership and the clinical expertise drama therapists can bring to NHS organisations. There are opportunities for drama therapists to play roles in prevention, in public health and in primary care. Part of keeping people well is enabling them to access ongoing support that can prevent them from needing the crisis support in the future. The impact of the creative arts on well-being is now widely being recognised. So with resources, drama therapists can lead on bridging projects between NHS mental health services and arts in the community, co-producing with those with lived experiences of mental health. And that is being done. Drama therapist skills in facilitating experiential workshops can be utilised in public health education. As a small and diverse profession, it's been difficult to build the evidence base to the level required for NICE guidelines, but we are getting better at evidencing the impact through local and national data collection and service user feedback and sharing our successes. The People Plan talks about making the most of the skills and energies in our wider workforce, about developing clinical leaders, about expanding capacity for clinical placements and creating a culture of belonging. We're ready and waiting, so please come and talk to us. Thank you.
Thank you, Claire. Wow, what a diverse bunch we are today. I'm just looking at the fact we're going to move now from drama therapy onto paramedics, which is quite a shift, isn't it?
It is.
But it's quite incredible to see the range of career opportunities available for AHPs, and thank you, Claire, for that presentation. So I'm now going to hand you over to Thomas, who's going to present some workforce data on paramedics. Thank you.
Thanks, Paula. As Paula said, I'm the one that's going to make the transition from drama therapist into paramedics for the second half of my double header. So next slide, please. So as I said earlier, three broad groups, I think, in terms of thinking about registrants. A podiatry where you'd have little growth, most professions where you get about 2 to 3% growth. And for paramedics, it's what you can see here is quite rapid growth in the last 15 years. So you can see that in 2008, there were 13,700 registrants. By the end of 2018-19 financial year, that has gone up to well over 27,500. So more than doubled in about 10 years. And if we go to the next slide, you'll see actually the scale of it. So you can see that between 2014 and 2020, your growth of registrants in the UK was by 37%. So that's really quite high growth. You're looking at 5.4% a year. It's an increase of just under 8,000 registrants. In August 2020, there were 29,760. So it's that level of growth actually continues, and if anything's gone quicker because it's a 7% growth on the end of 2018-19. So in terms of registrants, numbers are growing quite strongly. Quite interesting, a lot of registrants don't work in the NHS in England. Now, a lot of that some of it will be people working in other parts of the UK. What we're also seeing is that there's quite a bit of employment in other sectors, including increasingly in primary care, where we're beginning to see numbers come into that sector. Next slide, please. Quite neat here. So as I said, we used two different data sources, and what you can see here is actually they follow virtually the same trend. And what you can see is that your growth historically has been about 4% a year, but from 2017, that's actually the pace has picked up a bit. And that will reflect the fact that there's been quite a lot of investment in training in recent times. And that's shown in really quite faster growth. Although interestingly, the growth has been slower than the register. But what we are seeing is that we're getting a lot more growth in recent years. Next slide, please. Yeah, so in summary, yes, we can see 4% a year, but it's been well over 6% since 2017. And there's a variety of reasons. So some of it is that joiners from the UK has increased quite sharply from about 530 in 2014-15 to 1,100 in 2019-20. Similarly, your movement that you get sometimes within the NHS, that went up from 630 to 1,100. And a lot of that growth is driven by the big expansion in training places that's happened in recent times, notably under the PEAK programme. But it's not just that. What we also see is that there's been quite a growth in international recruitment as well. So going back to 2014-15, we were getting about 140 a year. By 2019-20, that had gone up to 365, so really 2.5 times increase in that time, and particularly among non-EEA than EEA, which is really quite interesting. In leaver rates as well, there's been efforts in improving retention, so it was 6.5% leaver rate in 2017-18. That's dropped to 5.7% in 19-20. So really, you've got a perfect environment for growth because you've got a lot coming in from education, you've got a lot coming in from abroad, and actually you're plugging your holes in the bucket as well. So you're not losing people out the side either. Next slide, please. This just shows you the variation by region. It's quite interesting in this case because actually there's a bit of spread between the different regions, and that'll be where you've got different ambulance services. So some regions, I think notably North East and Yorkshire, will have 2 ambulance trusts, others may only have 1. So the variation will partly reflect that. Next slide, please. In terms of demographics, very interesting stuff here. So in terms of gender, the thing that's quite apparent is that most paramedics tend to be male, 59%. And that's really, really unusual for an NHS profession outside medicine and dentistry. And certainly for all the HP presentations I've done so far and Shagufta's done so far, it's majority female. This is one where it's actually predominantly male. Age profile is quite interesting as well. It's you've got a lot of people who are quite young, so about 40% are under the age of 30, but you also have quite relatively high numbers over the age of 50 as well, so about 20%. So on balance, it's there doesn't seem to be immediate danger, but we do need to keep an eye on them over 50 leavers, because that is quite significant, and we will lose a few over the next few years. But the hope is that actually with younger people coming through, that can be largely mitigated. Next slide, please. In terms of ethnicity and nationality, majority are white British, and really quite small for paramedics from BAME backgrounds, only 2% really, so not an awful lot. Nationality is really interesting. It's a big outlier for HP. So in 2014, only 1% had non-UK nationality. By 2020, that has gone up to 7%. So you can see a 7-fold increase in that time. But in 2020, that represents about 1,250 out of 17,000 paramedics in England in the NHS. The thing that's really interesting when you look at the regional split is that London is a massive outlier. So most regions you're looking at about 2, 3, 4%. London, you're looking at 27% in 2020, which is an awful lot, and that will reflect particularly where there's been capacity issues in London, also where there's been quite a big recruitment drive by the London Ambulance Service. But it's a real outlier, particularly since it went from 2% to 27% in the space of 6 years. And in terms of what nationalities you tend to get, hopefully no surprise to paramedics, but you get a lot of Australians and New Zealanders. Interestingly, quite a lot of Polish and Irish as well, but the big influx has been from really the other side of the world. Next slide, please. So in summary, looking further ahead, all else equal, we would expect supply growth to be very, very solid. You're looking 5-6% a year, particularly given the current expansion that's going on in education and training. The challenge is around demand. So demand, we would expect that to be higher, about 4% a year, all else equal, which is what you tend to see within A&E trends and admissions. Post-COVID, it's likely though that's going to be, the demand will be even higher than that, and we know that under the long-term plan there are proposals for at least 2,500 additional paramedics in primary care, which will not only increase demand further but actually will require a possible shift in services, and that will have implications elsewhere, not least for individual ambulance trusts. So while all else equal, it all seems quite positive given supply growth. Actually, we need to really keep an eye on demand, because we not only because of A&E emissions, which we know will typically be about 3-4% a year, but also because there's a real drive to get more paramedics in community settings as well. Next slide. So in summary, very strong growth, over 6% a year in the last 3 years, quite a young workforce and increasingly international. I think it's really interesting for London, very high dependence on international recruitments. We're looking close to 3 in 10 from overseas, particularly from Australia. And the forecast, if there is such a thing as a forecast, pretty optimistic in terms of supply, but we need to keep an eye on what future demand looks like. And that's me. Thank you very much.
Thanks, Thomas. Hi, everybody. My name's Kirsty Lowry Richardson. I'm a qualified paramedic, qualified almost 17 years ago, having joined the ambulance service 3 years prior to that. I always knew that I wanted to be a paramedic, and that was cemented when I undertook some work experience with my local ambulance service whilst I was still at school. And I did actually go on to do quite a convoluted route to becoming a paramedic, because my school career advisor was determined that it was a dead-end job and it would leave me with no career options in the future. And I often wonder how that conversation would go if I were to bump into her in the local shop now. So I now divide my time between 2 roles, one being the Workforce Transformation Lead for the West Yorkshire and Harrogate Health and Care Partnership, where I support stakeholders in evolving their workforce to meet the new ways of delivering care to our communities. But this also includes a large focus on education and placement. And then one day a week I undertake the role of Associate Dean with the team here at HE in Leeds. And in this role I support the learning needs of trainee doctors and also the breadth of health and care learners across Yorkshire and the Humber. Both of my roles aren't what you'd probably immediately associate with being a paramedic, but I truly believe that my experience of being that critical thinking, pragmatic clinician, and then the education, supervision and leadership experience that I got later roles have perfectly prepared me with the knowledge and skills that I need for the roles that I occupy now. But that's enough about me, because I'd really like now to introduce a highly regarded colleague of mine whom I've had the pleasure of working with quite closely in the last 10 years, Liz Harris. Liz qualified as a paramedic in 2003, going on to undertake educator and supervisor roles. Liz was instrumental in the shift in the ambulance service provision from 2010 when she moved into a clinical pathways role, and she took the lead in implementing new care pathways for our clinicians to refer patients into as an alternative to simply conveying to the nearest ED. During this time, Liz secured a place on the National Leadership Academy Clinical Leaders Fellowship Programme, where she went on to complete a PG Cert in Service Improvement, co-facilitated by Manchester Business School and the King's Fund. Liz then took on the role of Clinical Development Manager in Yaz in 2012 and went on to complete her MSc in Leadership Management and Change at Bradford University. Liz was the College of Paramedic representative for Yorkshire for 5 years, and she's since gone on to an Executive Officer role in 2016. And Liz now holds the permanent position of the Head of Professional Standards at the College, and I'm delighted that she's here today with her presentation. Thank you.
Thank you, Kirsty. That was a great intro. Cheers. And Tom, thanks for the data. So here are some of the key challenges the paramedic profession faces and some of the opportunities for improvements and system benefits that we think there is. First slide, please. Some of the recommendations set out in the Peak report have been fully met, such as a move to BSc level entry onto the register, and as we've heard, the increasing of student numbers. Paramedics are currently the fastest growing profession, as Tom outlined. But some of the recommendations have still not been met, and they represent our challenges. Next slide, please. Current student paramedic numbers sit at around 7,000, with some improvements made in the numbers of students from diverse backgrounds. Unfortunately, though, individuals who have chosen to study paramedic science as a second degree are prohibited from accessing student loan financial support and also denied assistance from the Learning Support Fund. So no access to the £5,000 cushion to help students with dependent children, or with the cost of travel to clinical placements at shift times that just don't support, public transport doesn't support. Help is needed to reduce the inconsistencies in placement tariff and funding, and the opening up of organisations and placement opportunities for all. The level of respect and value placed on learners should be equal across all the healthcare professions. Another challenge is with regards to clinical education, so that delivered by the 47 universities who currently offer paramedic programmes. The range of placement settings provided varies considerably, and course content is still not standardised. Apprenticeship programmes seem to be going ahead with only ambulance placements on offer, so no maternity unit, no mental health, no paediatrics, no palliative care placements. And this variety of placements is vital in producing modern paramedics that are capable of meeting the needs of patients and the aims set out in the People Plan. As the system works towards increasing numbers, this cannot be done to the detriment of an individual's education and preparation for practice. So there's an opportunity for all those involved in educating and employing paramedics to work with us to quality assure undergraduate education, using our curriculum guidance as the mechanism for developing standardisation. The generalist nature and expertise of paramedics and their ability and flexibility to deal with unpredictable and unfamiliar working environments of frontline ambulance work gives the paramedic profession its strength. Next slide, please. Retention of paramedics is actually a problem for ambulance service employers, and no presentation on paramedic workforce should fail to mention the ambulance service cultural context within which the majority of paramedics still work. Ambulance services have the highest rate of sickness absence and bullying and harassment, and dismissal rates are nearly 4 times higher than other NHS trusts. Paramedics are twice as likely to find themselves enduring HCP fitness to practice processes, and with a self-referral rate that is 8 times higher than the average for all other AHPs. And with the context of the highest rates of suicide and PTSD amongst any professional group, this warrants some serious concern. The College of Paramedics is working extremely hard with a range of stakeholder organisations on prevention, intervention and postvention, and on implementing robust clinical supervision to prioritise paramedic wellbeing and to try and reduce some of these harrowing statistics. One innovation that was fuelled by the retention challenges is the rotating paramedic model. Next slide, please. This involves specialist and advanced paramedics employed by an ambulance service, rotating between a number of clinical settings, so GP practices, primary care MDTs, and then back into the ambulance service as one continuous role. This model has the potential to maximise the number of patients being managed away from EDs and help the whole economy increase clinical capacity to improve patient care in line with the ambitions of the long-term plan. Next slide, please. There are many examples in the devolved nations too of paramedics working alongside AHPs and healthcare colleagues in true partnership approach to deliver care in the community, supporting avoidance of hospital conveyance and subsequent admissions. Organisations that are embedding quality improvement methodologies on the front line by giving paramedics the skills and the tools to instigate the changes needed can see considerable benefit in terms of scale and pace of improvements. Next slide, please. This is what advanced practice looks like for paramedics, working not just in primary and urgent care, but in emergency and critical care settings too, with the medical colleges, exams and credentialing becoming more commonplace for paramedics. The College of Paramedics strongly supports the development of the multi-professional framework for advanced practice, which will ensure consistent standards of education and training, as well as providing a clear pathway for all clinicians who aspire or currently work within primary care, secondary and emergency settings. Paramedics are now highly sought after in numerous settings, and I'd like to add a word of caution here just to note about paramedic workforce numbers, alluded to in the previous data slides from Tom. Primary care demand is set at about 2,500, plus around 600 extra paramedics set out in the long-term plan for improved mental health care, plus approximately 4,500-ish to meet ongoing ambulance service demand. Currently, at least 6 out of the 10 English ambulance services have paramedic vacancies. So that's about 7,600 new paramedics needed, and fairly soon too. So we would implore leaders to apply a consistent approach to workforce data capture, aligning supply numbers with accurately forecasted demand numbers, but from a whole systems perspective. With advanced practice comes leadership responsibilities and opportunities for AHP leaders to support succession planning, ensuring that paramedics are afforded the same professional leadership development and access to senior leadership roles enjoyed by other AHPs and healthcare professionals too. Next slide, please. Prescribing came as a landmark achievement for the paramedic profession, and the subsequent benefits to the patient and the system have been seen clearly, particularly during COVID, with paramedic prescribers able to provide end-to-end care with reduced risk. Next slide, please. Since the inception of the paramedic profession, research has been a core component of our development. Our research centre has the skills, capacity and capability to lead on priority setting in research, carrying out our own research, innovation and quality improvement studies. Collaboration in research with other healthcare professionals is vital. Currently, that is mainly with medics across their many specialities, and so there exists the opportunity and an appetite from us to collaborate in the future across organisational boundaries and across the AHP professions too. Last slide, please. The dedication, versatility and autonomy of paramedics are attributes to be championed and utilised effectively, but also to be cherished. as is the entire healthcare workforce. If we looked after our people as well as we look after our patients, we could collectively open up a whole new level of well-being, growth and innovation. Thanks for listening.
Thanks very much, Liz. And thank you all presenters today. I think it's brilliant that you've stuck to time really professionally, and it means that we've now got a really good chunk of time for discussion and for comments. So I'm going to just hand over to Lucy a minute just to let us know what's going on in the chat box, please. And I'm also delighted to let you know that Beverly Harden has joined us. So she'd be more than happy to have a conversation with any of you. Sorry, my phone's just fallen off the table. So yeah, Beverly's happy to join in the conversation now. So Lucy, what's happening?
Thanks Paula, that we've had lots of great comments in the chat, and there's been quite a lot of networking going on too. I just first of all wanted to flag up that this is being recorded and there's all slides. You'll be able to access this webinar on the HE website. So I just really wanted to pick up on a couple of comments. So there was quite a lot in the chat about career pathways, especially apprenticeships from entry level all the way up to advanced practice and clinicians working at the top end of their license. So I just wanted to pick up on a couple of comments. So the first one really was for MENA. So we had a lot of dietitians asking about the apprenticeship for dietetics, saying that there are a lot of support staff very excited about this. So I just wanted to bring in Mena if you wanted to expand on that.
Yes, thank you. So just to say that obviously we've had the standard developed, and we currently have a training provider who is going through the process of registering in order to be able to deliver that. So that should be imminently, and we keep our website updated with all the information of that. So as I say, watch this space really, but that will be available shortly. There is an increasing level of interest in apprenticeships. There's slight variation across England, but there's certainly a high level of interest. And I think there is going to be future training providers coming on board sort of in the future. But as I say, if you have a look at the website, we'll keep you updated with all of that.
Thank you. And there was a couple of comments around for art therapy apprenticeship development, and maybe how that could link into developing a drama therapy course up in the north, because at the moment there seems to be a cluster of drama therapy courses around London and the Cambridge area. So I'm going to hand over to Bev, who's going to come in at this point to talk about that. Bev.
Thanks ever so much, Lucy. So we've got some fantastic work just starting initially in London, but onwards from there from the placement funding that was recently given out. And part of the brief to that group of arts, music and drama therapists across London is to look at how we start to enact the apprenticeship trailblazer that completed last year. So we have the standard in place. What we need to do now is move as a community across England to understand how we would look to commission that. And that will then enable us to hopefully put in place a national commissioning framework for all of the arts therapies to enable us to look at a very different level of provision, which on the phone call that we had, which is an incredibly excitable phone call, as you can imagine, was incredibly exciting as to the opportunity then to really start to drive educational models that are really going to start to help us to really think differently about the opportunities and how we really start to liberate the genius of the arts therapies into the wider system, not just the mental health environment. So hugely excited by that, Lucy.
Thanks, Bev. And I think my colleague Juliet would like to come in. She's got a hand up. Juliet? No, we've lost Juliet on that call, or whether she's taken a hand down, but she did say in the chat that she's very welcome to talk about how you can link some of those smaller professions and apprenticeships with developing new courses. So there was some area in the chat about confusion, and funnily enough, I had a conversation earlier this week with a colleague in mental health services about the confusion between play therapy and dance movement therapy and dance movement psychotherapy. These are not registered professions in the HCPC, but I just wanted to bring in Claire, whether you wanted to talk about some of the differences between drama therapy and those other professions.
Hey, I can say a little bit. I mean, dance movement therapy is we always considered it to be an arts therapy, but they are not registered with the HCPC. I think it was just about processes and time a long time ago. So they are now registered with the UKCP as a form of psychotherapy. So they went down that route, but we do consider this to be part of us. They just don't sit under the same umbrella. Play therapists, there's a lot of overlap again between drama therapy work with children and play therapists. I don't know much about play therapy specifically, but it's much more of a specific training and way of working, whereas I'd say drama therapists the training is quite very broad in the ways of working, and obviously work with lots of different client groups.
I think there's other comment. Thanks for the clarification. I think there are other comments in the chat box today about the difficulty in trying to evidence some of the outcomes from drama therapy to be able to support the development of new posts. I mean, certainly from my perspective, I found it incredibly hard to get a job within the NHS when I first qualified as a drama therapist, and it appears that some of those struggles are still there today.
Yeah, I think outcomes are key. I think in my trust we're fairly good with our outcomes. I think what we've done in answer to Helen's question on there is that it's making sure we're using very similar outcome measures to that psychological therapies are using. So if you need to, evidence and and it's not comparison, because you're often working with the people who aren't able to engage with the talking therapy. So that's really important to have in mind. But I think some of those routine outcome measures, particularly I'd say in maybe adult services where that's more easier to do or adolescent services than with young children or learning disabilities. But we use a lot of the same outcome measures, and also service user feedback is really important, and it's so important to collate that. So I'm really happy to advise anyone, and Louise, who's also on this, is extremely good at that as well. So happy to advise through BADSA on what we're doing.
Thank you very much. That's really helpful. I wanted just to move over to paramedics and about whether we could just bring in Liz at this point, because in the chat there was quite a bit about Mary Lovegrove, who talked about international recruitment. There's some ambitious targets in the long-term plan and the people plan around the increase in workforce numbers for paramedics. So if I could just bring in Liz, maybe just talk about those ambitions and how that's going to be met.
Yes, I think that currently we are benefiting from an oversupply of paramedics in Australia. So they have way more paramedic graduates than jobs, and we are benefiting from that. That at all cannot be something that we rely upon. For me, that international recruitment should be over and above and a nice to have, and not part of actually the core workforce planning strategy. It's great to have our Australian colleagues come across, definitely, and as Tom said, some from Ireland and Poland, to name two, but it can't be relied upon, and shouldn't be included in our planning.
Okay, we've got a hand up here, and that's from Louise Coombs. Do you want to come in and make a comment?
Hi. Can you hear me?
Yes, I can hear you.
Yes. I think my comment might have passed. I wanted to add that I think you mentioned about the difficulties. One of the difficulties in research is that there are so few of us in each section of the system. So, for example, I work in early intervention in psychosis, and I have for 9 years, and my job's only just been made full-time, not full-time, but an actual job. Up to then it was funded with pots of money because there was no evidence. But I can't do a clinical trial because there's no one else. And that's what we're dealing with.
Okay, I did, Claire, I presume that was just going back to the comment around drama therapy and the evidence base. Claire, did you want to comment on that?
Yeah, I need to echo that. I think Louise also sits on the subcommittee with me, so we talk a lot about this. But I think that's the hard thing about being a small and a diverse profession as well. A lot of evidence, getting the evidence, and Louise works hard on trying to get a manualised approach to share across, but it's really hard to get those research projects off the ground.
Thank you for that comment. I don't think there are any other comments in the chat box. I think we've just got one coming through now. As Liz said, it's all about quality. As a university, we're being pushed to increase paramedic student numbers, but we need to think more very differently about placements if we're likely to manage this. We are simply not seen as a priority as far as hospital placements are concerned. We could easily up the number of students, but we're not willing to compromise quality of experience. Liz, do you want to come back about that? Because it certainly has been an issue around placements for paramedics.
It has, and it's great to hear from Chris in terms of not wanting to, to jeopardise the future of their students in terms of their level of education. But it is quite simply a problem. We don't have a PR problem. All our student places are filled and probably could be several times over. So that's not the issue. But it is about making sure that those clinical placement opportunities across the huge range of settings that a modern paramedic needs are available. We just want equal access alongside all the other healthcare professions.
Absolutely, and I know that Bev would like to come in at this point.
So this is exactly for me the purpose of these webinars in so many ways. And when Liz and I were preparing for this, the absolute ask here, as Liz brilliantly said in her presentation, was we've really got to think differently about clinical placements, and coming together as an AHP community opens the doors for all AHPs to have access to clinical placements. And what's so exciting, we've got dietitians in primary care, we've got arts, music and drama therapists, needing to be outside of mental health services. And here we have paramedics who, if, as Liz said earlier, are not accessing theatres, maternity services, primary care, all the areas where the modern paramedic is absolutely key, mental health services. Paramedics go everywhere. And I think the magic is it's how do we work as an AHP community to move beyond me Beverly the physio sorting physio placements to me Beverly the physio thinking here is my sphere of influence that I can help look at placement capacity for. Clearly I need to get my physios in to do the physio stuff they need to do, but actually I could pop a couple of paramedics in here, I could have some ODPs come and follow my advanced practitioners over here. I could put some primary care teams in with multi-professional people going in to learn what primary care looks like. So I think there's a real creative opportunity here. And when I talk with colleagues around paramedic placements, the challenge is, well, how do I put a paramedic into a hospital when I haven't got a paramedic I can phone up and say, Liz, could you please take my 6 paramedic students, please? Because there is no Liz in the hospital. So how do we use the AHP faculty? And when Laura Ledsford gave the birth the idea of the AHP faculty all that time ago that Paula has made reality with colleagues across the country, the aim was to have somewhere that we could phone to say, we have got 73 paramedic students who need fantastic quality experience in your system, how can we place them? And then we have a dialogue where we can go sort things out together as adults, because the patients need all of us, the population needs all of us. So I think that's our challenge as a community together, is how do we create room for everybody? How do we value everybody? And how do we ensure that there is, placement opportunity, but across the breadth, not just in the traditional places? And from Liz raised issues around placement tariff and all the various underpinning challenges. All of that is being discussed at the moment. All of that is absolutely in debate. These things take time, clearly, but the thing that we can do now together is impact on the accessibility of placements for colleagues and liberating whatever placement tariff we do have to the benefit of the whole, not just to me, Beverly the physio.
Well said, Bev. Liz, did you want to add any comments on that?
Nothing other than, it's great to hear that support from HE, because as singular professional bodies, our impact is limited. And so as we all work together with HE, then hopefully we can achieve something. Great.
There is no more comments, apart from one from Louise, who's talking about the structural difference between art, music and drama as psychotherapists who are registered with the HCPC rather than the UKCP. So that's a really good point, Louise. Thank you. Is there anybody else? Or Mary Lovegrove has got a hand up. Mary, would you want to come in at this point to make a comment?
If I may, Lucy, thank you very much. I just want to follow on from Beverly's brilliant view on how we could probably address some of these clinical training capacity challenges. So as many of you will know, there's a great deal of work going on now with a big national project that HE is leading on called the Repair Programme. And one of the aims of that is to ensure high quality clinical learning environment for all learners. And as part of that work, and alongside some of Beverly's bespoke work, we are looking at a model of a formulaic approach to the clinical training capacity in theatres. And that's really important, and we recognise, and we've done quite a lot of scoping of the data, how important it is for paramedics to have access to that alongside other learners. But it's very important that we keep in that context that everybody is trying to get learners into theatres, for example. So there's the massive increase in pre-reg nursing numbers, which are just phenomenal, and many of the universities will be seeking theatres as one of their choices to put in these vast numbers of new nursing numbers. So with that in mind, HE is bringing together deans in a geography, in a location, to talk to them together to understand what flexibility there are within the education and training programmes, because it's critical that we start with the universities and their approach to placing learners. So I just wanted to add that. I hope that's okay, Beverly. I just wanted to, I can see you nodding at me. That's absolutely brilliant.
That's a great comment. Thank you very much, Mary. I'm aware of time. We've just got a couple of minutes left. And we've just got one more comment, time for one more comment, and this is to Liz. If I understand correctly, there's not a consistent curriculum for paramedics in training. What then are the challenges and support needs for supporting paramedics to achieve advanced practice? A good question from Deborah.
Yeah, thanks, Deborah. I noticed it earlier, so I'm glad we've come back to it. So the standards of the curriculum guidance through to advanced practice is being written, and we will obviously be supporting the multi-professional framework. I think the challenges have been that advanced practice within ambulance services has not at all been supported across the board over many years. So in one way, paramedic profession is playing catch up. You'll have seen all those my colleagues in advanced practice on that slide, but they're there because of their own dedication and determination and their own ability to pay for their advanced practice education. They've not at all been funded by any kind of national model. So we're playing catch up with that. So what we need is more of a national approach to getting paramedics through advanced practice modules, the funding, of course, to get them there, and the release from their clinical roles too.
Great. Right, we're at 12:14 and I know this broadcast needs to finish in a minute, so I'd like to take this opportunity to thank all our speakers and just hand over to Paula.
Thank you very much, Lucy, and thank you for supporting today's session by managing the chat box so brilliantly. So I just want to thank Sharon Kibble and Jane Gardner-Florence, who have been behind the scenes helping to sort today out and to keep things running smoothly. I think people have found it easier to get in today than in previous sessions, so we're on the right track. We've got 2 more AHP workforce sessions planned. So we've got speech and language therapy, music therapy and prosthetics and orthotics on the 29th of September. And we've got diagnostic and therapeutic radiography along with osteopathy on the 30th of September. So please join us for that if you can. All the sessions are recorded and will be on the HE website on the AHP faculties platform. So if you just put HE AHP faculties, it takes you through to the website. If anybody wants to find out more about AHP faculties, if you aren't currently part of a faculty and you would like to be, or you were thinking about setting one up, then please get in touch with me, because we're looking at putting on a workshop in November to help those systems who don't have a faculty to set one up and to look at mentoring with existing faculties. So please get in touch. And then one final point is just around data. So if you would like, we've obviously heard had a lot of data presented to us today, so thank you so much to Thomas and Shagufta for that. But if you wanted to look in more detail at your own specific systems and workforce data, then I would urge you to get in touch with your HE AHP leads, who can then signpost you and put you in touch with your workforce planning leads at Health Education England, because regionally we have those roles in place and they will have your system and region data. So please do get in touch about that. I think that's all for today, but thank you so much for joining us. I hope you found it useful, and please do utilise the information you've been given to drive forward those conversations with your HR directors and your system leaders, and advocate on behalf of the professions. Thank you for your time.